The assessment of left ventricular end diastolic pressure is a cornerstone of hemodynamic evaluation, particularly in heart failure. While the gold standard remains cardiac catheterization, echocardiography provides a robust, non-invasive framework. The primary method for estimating left ventricular end diastolic pressure, or its surrogate, the pulmonary capillary wedge pressure, involves evaluating the relationship between mitral inflow and myocardial relaxation. That is the E by E prime ratio. This is the most widely used index. It correlates the early diastolic mitral inflow velocity E with the early diastolic mitral annular velocity E prime. Normal E by E prime will be less than 8, usually implies LVEDP less than 12 millimeters of mercury. Elevated E by E prime more than 14, highly suggestive of elevated LVEDP. The gray zone is 9 to 13, which requires additional parameters. When E by E prime is inconclusive, following findings support elevated LVEDP. Left atrial volume index LAVI more than 34 ml per square meter. Peak TR velocity more than 2.8 meter per second indicates elevated pulmonary artery systolic pressure. Mitral L wave, presence of a mid-diastolic flow wave, suggests significantly delayed relaxation and elevated filling pressures. If significant valvular regurgitation is present, we can use the Bernoulli equation, that is 4V squared, to derive pressures at specific points in the cardiac cycle. Aortic regurgitation jet. The end diastolic velocity of the AR jet reflects the gradient between the aorta and the LV at the very end of diastole. LVEDP is equal to diastolic blood pressure, that is cuff pressure, minus 4 times the square of end diastolic AR jet velocity. While the peak MR jet informs systolic blood pressure, the negative dP by dt, rate of pressure fall, can indirectly suggest LV compliance, though it is less commonly used for a direct LVEDP number. Left atrial reservoir strain has emerged as a sensitivity marker. A reduction in LA reservoir strain often precedes changes in the E by E prime ratio and strongly correlates with rising LVEDP. Lung ultrasound B lines. While not a direct measure of pressure, the presence of multiple B lines, that is comet tails, indicates pulmonary congestion, providing clinical bedside evidence that LVEDP has exceeded the threshold for transudation. It is important to remember that non-invasive markers can be fooled in specific scenarios. Mitral annular calcification renders E prime measurements inaccurate. Significant mitral regurgitation often results in a high E velocity regardless of LVEDP. In atrial fibrillation, variability in cycle length requires averaging multiple beats and relies more on the peak TR velocity and IVRT, that is isovolumic relaxation time. Here is a simplified summary. Average E by E prime less than 8 in normal filling pressure, more than 14 indicates elevated filling pressure. LA volume index less than or equal to 34 ml per meter squared, normal filling pressure, more than 34 ml per square meter, elevated filling pressure. TR velocity less than or equal to 2.8 meter per second, normal filling pressure, more than 2.8 meter per second, elevated filling pressure. Septal E prime more than or equal to 7 centimeter per second, normal filling pressure, less than 7 centimeter per second, elevated filling pressure.